Martin Luther King Jr. once said, "Of all the forms of inequality, injustice in health is the most shocking and the most inhumane." At UW Medicine, we believe that everyone deserves equitable quality of care. One of our core values is that we embrace diversity, equity, and inclusion. While we've done some good work in this area, we recognize we have much further to go and are committed to transforming the way we deliver care to eliminate inequities. Doctors Pat Dawson and Paula Houston are leading the team responsible for UW Medicine's strategic priority around healthcare equity.
Healthcare equity is really our effort to ensure that the care that we're providing to our patients is really addressing the needs of the patients that have been most marginalized, historically oppressed, with the ultimate goal to decrease health disparities, and that means making sure everybody has the same opportunity to have a good health outcome.
In 2016, an interdisciplinary group of advisors developed a multi-year strategy, or blueprint, for how UW Medicine can improve healthcare equity, focusing on three main objectives. The first, addressing workforce; the second, on community; and the third, on clinical transformation.
And then the third piece is taking the data that we have about disparities in healthcare that we can cut by clinic, by race, by language, and looking at areas that we can make interventions. The disparity index is a way of quantifying how disparities are, and so it looks at how people of color are not getting a service relative to how white people are not getting a service. And so they can use that ratio to look at disparities across the system.
Diabetes retinopathy screening cameras are one example of a healthcare equity program put in place through this focus.
We realized that diabetes care was one of the areas where there was a great disparity, and we knew that we had one clinic over at Harborview that was not seeing a disparity, particularly in their African American population in getting diabetes retinopathy screening, and that was because they had a camera in place that was a very low barrier way to get screened. The clinic staff could do it rather than having to send patients to an ophthalmologist. So we looked across our system at several other clinics that had high disparities and decided that this would be a really good way to have a very specific issue addressed in a way that is better for the patient.
We've actually been screening patients with diabetes for retinopathy for about 9 years now through the UW Medicine Eye Institute in conjunction with the adult medicine clinic at Harborview, and the program was extremely successful. The adult medicine patients at Harborview had an extremely high rate of getting their annual eye checks, which is something that's very important for health maintenance for diabetic patients. And the idea came about how to improve access for our patients and how to simplify their lives. There are certain ethnicities who are more prone to the development of diabetes. For example, Native Americans and Hispanics have a higher percentage. And as a Latina myself, I see the burden of that in the population, who in many cases might not have access to care. So I'm very sensitive to that. And I think if we can provide a service to put everyone on a more level playing field, that's just one more thing that stands us apart from other health systems.
Prior to having the retina camera available to us in the clinic, we would need to ask our patients to see an eye doctor in order to get their annual retina screening. If my patient who had to think hard about the gas money that he spent to get to my appointment now has to spend some more gas money to get to an eye doctor somewhere else, that's a barrier for him. We didn't have much control over where they would be going or know what the quality of the examinations were. And then we would have the difficulty of having to gather that information back into the medical record to make sure indeed that it had been done.
I would have to drive to Seattle, downtown Seattle, and have it done by the specialist there. You would have to have your eyes dilated, wait 20 or 30 minutes for it to come into effect. They would give you also numbing drops, Yeah, and it just wasn't fun.
This type of process where we are bringing the University of Washington to our patients here in the suburbs is very valuable for continuity of care, excellence of care, and for just decreasing the barriers of care for our patients.
But we have had some really important saves. I'm thinking of one gentleman who had diabetes for many years. He came very close to losing his eyesight, so I'm very grateful that the screening cameras were there for him. Our goal is to make sure every diabetic patient has that opportunity to have the eye care that they need to keep them seeing well throughout their lives.
This procedure right here is so much quicker. It's less invasive. It's just really awesome.
We're leaders in education, we're leaders in research. There's no reason why we shouldn't be leaders in providing equitable health care and making sure the patients that come through our doors have a good experience and are having good outcomes regardless of their race, ethnicity, language, sexual orientation, or any other characteristic of diversity. It's also just the right thing to do.